My name is Jürgen Rockstroh from the Department of Medicine here at the University Hospital in Bonn, and it's my pleasure today to speak about progress in hepatitis C, B, and Delta. So this is an exciting topic because there are quite some advances. Let me first start, though, by sharing my conflict of interest, and then move right into issues around hepatitis B. Now, as you're all very well aware, there is quite a high number of people living with chronic hepatitis B, over 296 million. The last count was in 2019, and the majority are actually also in the African region. So clearly something which is of pivotal interest in your country. Please keep in mind that 7.4% of persons with HIV also have hepatitis B co-infection, resulting in overall 2.7 million persons. And I think one of the only very positive news around hepatitis B is that the global target of hepatitis B surface antigen prevalence of below 1% for 2020 among children younger than 5 years is one of the first 2020 targets of the Health-Related Sustainable Development Goals, which has been met. So vaccination is up and rolling and does serve its purpose, but obviously there's still some issues otherwise which need to overcome. And this becomes also clear in the more recently published WHO Hepatitis Report 2021. And if you concentrate on the lower bottom and the African region, you can see there's still 990,000 new infections of hepatitis B, 80,000 deaths accountable for hepatitis B infection. And that's much higher than actually new infections for hepatitis C with 210,000 and deaths related to hepatitis C of 45,000. So this remains a big issue, not only the region, but in many parts of the world. Now, in the setting of HIV, hepatitis B sticks out that in particular before antiretrovirals, so before we had these wonderful antiviral drugs, the mortality of people living with HIV who had hepatitis B on top was significantly enhanced. So the risk of dying from liver disease was clearly much higher in the setting of HIV, and that was related to faster fibrosis progression and cirrhosis occurrence in the setting of immunodeficiency. Now, when the antiviral drugs became available, obviously quite a number of them were dually active against HIV and hepatitis B, which made it very promising to use these drugs, obviously, particularly in co-infected individuals. And although 3TC significantly lowered mortality for hepatitis B HIV co-infected individuals initially, it became apparent that there was a high rate of resistance development. You see here the 5-year resistance rate for 3TC with 70%, which is very high. And so clearly these drugs are no longer recommended as first-line agents, whereas entecavir and tenofovir have been developed as the recommended agents due to their low resistance profile. And you can see indeed tenofovir, which is of particular interest in our HIV co-infected individuals, so far hardly any resistance has been described. And as a consequence of that, all people living with HIV who have chronic hepatitis B and HIV co-infection should receive an antiviral therapy that includes TDF or TAF, unless there's a history of tenofovir intolerance. So clearly that is the preferred regimen. And I think one of the things we have to keep in mind is that stopping anti-HB active ART should be avoided because then there is a risk of severe hepatitis flares and decompensation following HBV reactivation hepatitis. Now, the optimal treatment duration isn't so clear. Obviously, seroconversion would be highly desirable, but that will not occur in all patients. So many people are really stuck for lifelong therapy. Now, since HIV will also be treated lifelong, I guess that's something we can all live with. But remember that particularly with the onset of new modes of administration, long-acting therapy, you may switch someone who has a background of hepatitis B to a regimen which does not any longer include a TDF or TAF component, and then you may see a liver decompensation or a flare of liver enzymes following re-emergence of the hepatitis. So that's something to watch out for. If you switch a patient who had a chronic hepatitis B, always make sure there still is an HBV therapy in there, unless seroconversion has occurred. And then there's some guidance here around treatment monitoring. Now, there's some particularities around treatment of hepatitis B in patients with HIV, and this is from a study which is relatively small, but gives interesting data with regard to the amount of people and the time to suppress by baseline hepatitis B viral load when they receive a tenofovir-based antiviral therapy. And you can see that after 1 year, there is still a large proportion of 54%, which had incomplete HBV DNA suppression. And this incomplete suppression was associated with higher baseline HBV DNA. So that could be particular patients with wild type infections, so HB antigen positive. And that means that there is a longer time for us as clinicians to follow a patient C until they become undetectable. Obviously, replicating consistently may also increase your risk for development of hepatocellular carcinoma. So it remains an issue, and there also is an age-related impact on the time to suppression. Now, one of the more exciting findings around hepatitis treatment for B and HIV co-infection is that indeed you may see a higher seroconversion rate. And why is that so? Well, remember that if you get infected with hepatitis B while already having HIV, your likelihood of chronic infection is probably 6-fold higher. And remember that HBV is an immune-mediated clearance mechanism. So if your immune system doesn't work anymore or not as good because you have HIV, well, then you're probably ending up with chronic infection. But maybe you would have been able to clear the infection if you wouldn't have become HIV infected. So really, starting antiviral therapy, regaining immune competence could entitle you to a better immune response, allowing seroconversion. And that's exactly what we see. So in this study from various German centers, we were able to describe a seroconversion rate, so loss of HBs antigen, in a long follow-up of a median of 41 months of 18.4%. So telling us that there is quite a considerable amount of people who actually become HBs antigen negative or lose their HBs antigen under suppressed replication under antiviral therapy containing, in this case, mostly tenofovir-based regimen. Now, that is different because if you think of the registrational trials in monoinfection, that occurs at a much lower rate. So that's something to watch out for, because that means that in clinical practice, you may want to regularly monitor your patients, because if they do seroconvert, then there is no longer necessary need for example, tenofovir in case you want to switch to long-acting, or because of renal issues, you can't give tenofovir or TAF is not available. So that's something to keep in mind. And then there's another exciting piece of information which originates from a Dutch trial, which also subsequently was shown in a Japanese cohort and other cohorts throughout the world, really showing how do people perform who have HIV infection and are not vaccinated for hepatitis B, which obviously they should according to guidelines, but somehow that has been missed, and are on a antiviral therapy which either contains no HBV active agent or a tenofovir component or something else, but not tenofovir. And the interesting thing here is that if you're on tenofovir, you probably have a very low probability of getting infected with hepatitis B. So kind of tenofovir in HBV anti-HBs negative individuals, so those who have no response because they were not vaccinated and have no sign of prior infection, so anti-HBC negative, if they have tenofovir, that's very unlikely that they will become infected with hepatitis B. So it also protects against acquisition of hepatitis B. One important thing to remember is that patients with chronic hepatitis B are at an increased risk of developing hepatocellular carcinoma. And so screening for HCC is indicated in these individuals, in particularly if they have cirrhosis. But remember that this is also in other patients for HPV co-infection, because there is that higher risk of HCC. So people with a family history of HCC, Asian or African ethnicity, so including people from your own country, Delta co-infection in older patients should also be screened, even if they don't have cirrhosis, with ultrasound, with or without AFP, so alpha-fetoprotein, which you can determine by blood draw every 6 months. So that's important to keep in mind. So another important infection we're beginning to learn more about is hepatitis delta. Now, hepatitis delta is a viral infection which is caused by the Delta virus. It is something which can propagate only the presence of hepatitis B virus. So it occurs either as simultaneous infection with hepatitis B or superimposed on chronic hepatitis B or hepatitis B carrier state, it's superinfection. and it's considered the most serious type of viral hepatitis due to severity of complications, higher risk of liver failure, acute infections, and also rapid progression to liver cirrhosis. So it really is something where we would really urgently need a treatment possibility, but that so far has been very limited. But indeed, it's kind of a neglected infection too. It's not screened regularly. The guidelines have been sort of diverse in the recommendations who to screen. There was a recent presentation from Taiwan, which I found very interesting at last year, CROI from Taiwan, which looked at HIV positive individuals seeking HIV care at the National Treatment Center at the University Hospital. And they screened 505 HBs antigen positive patients. Remember, you have to have HBs antigen to get a Delta infection, and found that 8% actually had HDV infections. That's pretty high. And whereas we believed that in Europe, this is mostly to be found in people who use drugs, interestingly, there was also quite a number of men who had sex with men who tested positive for Delta infection, telling us that this is also something which can be found in other vulnerable key populations. And I think there is a bigger need for more data on the incidence and prevalence of Delta infection throughout the world. Now, what caused real discussion and excitement is that a new drug has been developed called bulevirtide. It's a first-in-class entry inhibitor for treatment of chronic hepatitis delta virus infection. It blocks the sodium terosholate co-transporting polypeptide receptor, so that is expressed on the hepatocyte, and as such can prevent the infection of hepatocytes with the hepatitis delta variant. It's administered subcutaneously with 2 milligrams daily, and it has received conditional approval in Europe and is being used now in patients with cirrhosis or more advanced fibrosis stages. I'm not going to walk you through the whole development program. I just thought that at the recent AASLD, the French colleagues presented data from their Expand Access program, which was very interesting. It's a non-randomized, multi-center observational study which looked at the changes in viral load for hepatitis D or normalization of elevated liver enzymes, and was a comparison which was done by the discretion of the physicians who could either give just bulevirtide or add PEG interferon. Remember that PEG interferon has been used for treatment of Delta with pretty dismal results and obviously also a lot of toxicity, very long durations of treatment and not very successful. The baseline characteristic here, and this is a sizable group of 77 individuals who received just bulevirtide subcutaneously 2 milligrams per day, and then there were 68 in the combination arm. You can see this was a mostly male cohort, very advanced, over 60% had cirrhosis. You can see that there was quite some liver enzyme elevation, and you can see that most of them were, though, undetectable for hepatitis B and on current HBV active antiviral therapy. And that was the interesting part. There were also individuals who had an HIV co-infection who were included into this ATU program. If you look at the change in Delta viremia over time, you can see that there was a numerically somewhat higher decline in viral load for those who received the combination therapy. But remember, the study is not powered to compare the two treatment arms, so there was a significant decline, I would say, in viral load for pretty much all of them. And then you can see the changes in liver enzymes were pretty much similar between the two treatment arms, and there was a significant reduction of liver enzyme elevation. And if you look at the combined response, either undetectable viral load or at least a 2-log decrease from baseline and normal liver enzymes, you can see that this was achieved in almost something between 30 and 40%, irrespective of which arm the patients were in. So telling us there is considerable efficacy. I think one problem is that we don't know how long to treat. We don't know what the outcomes are we need to monitor for. Obviously, this is given so far as long as you see a suppression of viral load and a normalization of liver enzymes. If that starts to increase again, then that's where you usually stop, but we don't know how long to treat yet. So there's clearly a need for more information. Looking at the safety, it was overall well tolerated. I think one common side effect is an elevation of bile acid. So that's something to watch out for, but it doesn't lead to a lot of clinical complaints. And so I think overall, the tolerability was very acceptable. So in conclusion, I think this observational cohort showed us that The current dose of 2 milligrams given subcutaneously showed favorable HDV RNA declines and liver enzyme normalizations. The levels continue to decline throughout 12-month treatment. It was well tolerated, few discontinuations because of adverse events, and no new safety signals. Bile acid elevations, as mentioned before, were asymptomatic and expected, and the data is very much in line with the phase 3 development program. So at the end, I want to talk a little bit about hepatitis C. Now, obviously, there is a big overlap between HIV and hepatitis C, particularly intravenous drug users were probably throughout the world, 80% of those who have acquired HIV through drug use have also a concomitant hepatitis C co-infection, much less if heterosexual transmission is your driving HIV transmission cause, and more increasingly now also in the MSM patient population, particularly in those who are exposed to traumatic sex practices. You can see that the numbers are shown here are something which affects globally. All continents are involved. Now, as the direct acting antivirals have been developed, great treatment success is now possible without interferon, and that has really revolutionized hepatitis C therapy. And you can see that it is at least reassuring to see that 9.4 million people have received treatment to cure chronic hepatitis C infection, which is a 10-fold increase from the baseline of 1 million at the end of 2015. And this is taken from the Global Progress Report on HIV, viral hepatitis, and sexually transmitted diseases from the WHO from 2021. And I think that's at least some good news. The scale-up has also been sufficient to reverse the trend of increasing mortality from hepatitis C for the first time. There are obviously some pioneer countries which need to be mentioned, particularly Egypt, where universal access to treatment has resulted in an impressive decline in mortality and incidence of hepatitis C. But obviously, there still is a high number of people dying from hepatitis C, and that is obviously daunting. And clearly, with the advent of these highly efficacious therapies, this needs to change. Now, in the context of HIV, remember that hepatitis C disease remains faster. So there's a faster fibrosis progression, even in the setting of antiviral therapy. So if you get an increase in your CD4 count, at least that prevents very fast progression. And you can see here that in the sub-analysis here from the veterans, that if your viral load is less than 1,000 copies, that's better than above 1,000 copies. So viral control of viral replication is essential, but also having a CD4 count above 200 really improves your outcome. But if you have low CD4 count or still replicating, then you still have a much faster fibrosis progression. So as a consequence, because of the poorer outcome of hepatitis C in people living with HIV, the guidelines here from EX again clearly state that every person with HIV and hepatitis C co-infection should be considered for DA-based anti-hepatitis C treatment, regardless of liver fibrosis stage. That was only early on where we thought we might have to wait. There were cost issues, but as drugs are becoming more widely available and cheaper, we really believe everyone should be treated regardless of fibrosis stage. And really, because of the now comparable cure rates, which was not the same in the old days when we gave interferon, where HIV patients respond less favorably. Now with the same kind of cure rates and the same tolerability, we have really the same recommendations as in monoinfection. So there's nothing special anymore. And you see in the EX table, there are a whole range of different combinations. So it depends a little bit what you have available in your country. But obviously there's some drug combinations which are particularly advantageous, and that is sofosbuvir velpatasvir or glucoprevir pepentosvir, because these are pan-genotypic regimens which can be given between 8 and 12 weeks in most cases. Remember, there's some restrictions. If you have a decompensated cirrhosis, then hepatitis C protease inhibitors cannot be given. But with these pan-genotypic regimens, you don't even need a genotype test, and you can really treat pretty easily. Now, one of the special things which remains is that you have to check for drug interactions between hepatitis C and HIV drugs. Or there's a very wonderful Liverpool website which allows you to exactly see what kind of drug interactions you may expect. This table summarizes some of the main interactions, and you can see that at least for the integrase inhibitors, which are now commonly used in Africa as well as in most other countries in the world, as well with NRTIs, there's little interaction to worry about, whereas with some of the PIs, And with efavirenz, there were really quite some contraindications, which made the co-administration complicated. But now, as we are in an integrase inhibitor-based regimen era, I think it's become much easier. I just put in 2 slides on the outcome of hepatitis C therapy in people living with HIV and hepatitis C, just to highlight that in this Austral-5 study, which included treatment naive and experienced, non-cirrhotic and cirrhotic genotype 1 to 4 adults, the cure rates are amazing. So whether you have advanced liver disease or not, whether you have failed a previous treatment or not, they all are between 93 and 100% response rate, which is fantastic. And I think really highlights that the DAs have really changed the hopes and the expectations we can have with modern DA therapy. This is from the Expedition 2. This is the other pathogenesis regimen, GP, the Kappa-Pir-Pentasphere, and again, you can see 99% in the modified intent to treat achieve cure of hepatitis C. There was only one individual with cirrhosis and a genotype 3 infection who was non-compliant who failed. Everyone else responded, and I think that just tells us that we have equally well SVR rates to expect in our co-infected individuals. And that all in the light of really great tolerability. You see that the discontinuations because of adverse events were less than 2% overall, just really highlighting that this is a very well-tolerated therapy. Now, for a lot of people, and this is something which is also of value in Africa, is obviously the question of how much pre-testing and how much testing during treatment do you really need? And there was an ACGG study called MINMON, standing for minimal monitoring, where the patients basically just got diagnosed and then initiated therapy. There was some remote contacts at week 24, at week 4 and 22. But overall, what you can see, although not everyone was able to take the entire dosage and some people dropped out, but overall the cure rate was 95%. So really fantastic. Clearly, this is something which I think is encouraging and may tell us that we do not need the extensive monitoring, which we may have done early on, but probably just treating. And if you check maybe one time after 12 weeks after end of therapy should be sufficient. And there was also a lot of different ways of trying to keep individuals living with hepatitis C who were in this trial motivated to stay on treatment, and looked as if social media was more stable than by telephone contacts. Just one other point to raise, in that there is an outbreak of recently acquired hepatitis C among people living with HIV, sometimes in people who use drugs, but more commonly now also in men who have sex with men. And there has been a pledge to treat these individuals once diagnosis has been confirmed early. So if they have a repeat hepatitis C or an A after 4 weeks and they do not show a 2-log drop, they're not going to spontaneously clear their infection, and as such, they can be treated as early hepatitis C infections, and that will have an impact on further transmissions. And we're seeing from many trials where people are treated early that this has a very favorable impact on new incident hepatitis C infections. And I think what is really the most reassuring thing is that with these drugs becoming available in a country where the co-infection rates were very high initially in Spain, you can see that the prevalence of hepatitis C has dropped dramatically with an increase in treatment uptake. You see that it went down to 2.2% among people living with HIV in Spain. So that is a 90% lower prevalence than in 2015, clearly highlighting that elimination of hepatitis C among people living with HIV, at least in Spain, is an achievable goal shortly. And this is something which should really be possible everywhere in the world. So in summary, there is a significant reduction in liver-related mortality in HIV, HBV co-infection with HBV active heart. If you require treatment for hepatitis B, use a tenofovir-based antiviral therapy and start at any CD4 count. It may take a little bit longer to become undetectable. Remember that there is a higher proportion of individuals with HIV, HBV co-infection who may actually lose HBs antigen after starting tenofovir-based antiviral therapy. In those who do not respond to hepatitis B vaccination, tenofovir-containing ART can prevent new incident HBV infection. Don't forget to screen for Delta infection, and every person with HIV and hepatitis C should clearly be considered for DAA all-oral therapy. The regimen's indication very much similar to HCV monoinfection. Remember to check for potential drug-drug interactions if you have more complex HIV regimens, particularly involving a protease inhibitor or efavirenz. And clearly, hepatitis C elimination is achievable and something we all should work on together. And with that, I'll close and send you a friendly hello and very happy to answer your questions in the Q&A session. Thank you very much.